Hello, very good evening to everyone. So, as we are advancing into medical sciences, we research, we lay down the diagnostic criteria for various diseases based upon the pattern how the disease behave. And but then there are always these outliers which challenge our existing knowledge, and those cases are the ones which keep us going. So, one such case I'll show you here, which belongs to a 16-year-old girl visiting to our OPD with this retinitis lesion. The lesion, as we can see here, it is next to this pigmented scar. It is oval shape, yellow colored. The diagnose, and it is at the macula. So the diagnosis of toxoplasma retinochoroiditis was made here. Only later to realize that it was not so. So we clubbed all such cases which were on prima facie diagnosed to be of toxoplasma retinochoroiditis. So why was this confusion at first place? So because toxoplasma retinochoroiditis is the most common infectious cause of posterior uveitis, and pretty often the diagnosis is clinical because the lesion is unifocal or maybe paucifocal, which is associated with vitritis, and plus minus there could be there is vasculitis, plus minus there could be vitritis, and plus minus there could be adjacent pigmented scar at times. And on OCT, if we see the lesion, it is full thickness and there is associated choroiditis. At times, there could be granulomatous anterior uveitis as well. So we conducted this retrospective case series, in which we included very well documented cases of toxoplasma retinochoroiditis, which were diagnosed on prima facie. And so why did the confusion occur at first places? So in our case series, what we found, the most common mimicker was retinitis lesion that was adjacent to a pigmentous scar. That was followed by vitritis and vasculitis. And based upon this, even in the anti-protozoal therapy was started in 8 of the patients. Then how did we finally arrive at the correct diagnosis? So that was based upon mainly deep vitreous biopsy, serology, and that was supported by OCT, whether independently OCT or independently deep vitreous biopsy. So now, going back to the case that I had shown in the beginning, this girl was treated multiple times with the anti-protozoal therapy, and this was her OCT. So here OCT was proved to be the revealer, and we can see in this OCT there the lesion has relatively preserved inner retinal layer, and the true revealer in this case was this contact sign, which was the true revealer of tubercular chorioretinitis. So then this patient was started on anti-tubercular therapy, and soon the lesions were healed. Another such similar case I want to show here. So again, here the lesion is quite similar, pigmented, unifocal at macula, which is adjacent to a pigmented scar, and also we can see there is vasculitis. On FFA also, at the site of lesion, there is hypofluorescence surrounding hyperfluorescence. So this look pretty much like toxoplasma chorioretinitis. But now, if we have a look at the OCT, we can see there is this subretinal lesion of retinitis lesion that is kind of pushing the outer plexiform layer. So the focus is mainly in the subretinal layer, contrary to what we see in toxoplasma, where it is full thickness. And finally, this case was turned out to be of fungal etiology based on the vitreous biopsy. So in our study, we found the diagnosis were fungal in 46% cases, followed by tubercular, toxocera, and syphilis. So to summarize, focal retinitis with or without adjacent pigmented scar is not always pathognomic of toxoplasma retinitis. It can be seen in other infections, which in our study we found they were fungi, tuberculosis, toxocera, and syphilis. OCT and vitreous biopsy for culture and PCR were instrumental in revision of our diagnosis, and OCT identification of rain cloud sign, subretinal location of the lesion, preserved inner retina were the key features of fungal infections. And microbiological evaluation of ocular fluids like smear, PCR in atypical cases can prevent the diagnostic and treatment delays. Thank you for your patient listening.
Thank you, sir. Sir, your comments. We are waiting for your comments.
See that you have told about fungus tuberculosis. The tuberculosis cases was a blood vessels are going over the choroid.
Yes.
But one of the thing is that viral retinitis can also mimic toxoplasmic retinochoroiditis, and reversely, toxoplasmic retinochoroiditis can also mimic viral retinitis. I just missed a case few days back.
Oh.
So viral retinitis, they can be in the posterior pole, and they can mimic toxoplasmic retinitis because their retinitis OCT will be helpful.
Yes.
OCT will show the retinochoroiditis in toxoplasma, whereas the viral retinitis, it would be retinal lesion,
Yes.
not the choroid
Choroid.
lesion.
Thank you so much for this inputs.
Sir, your clinical pearls to distinguish TB and toxo, just for the benefit of everyone present here.
So that TB will be a choroidal lesion mainly, whereas the TB retinal TB is almost unheard of. And then it could be either choroiditis or choroiditis with retinal involvement or subretinal abscess.
Thank you, sir. Thank you.
Thank you.